Good morning, and thanks for coming today. I know you guys all know who I am, but for the sake of people who may see this later on in the video, I'm Dr. Trina Nguyen with the Department of Anesthesia at Downey PIH Hospital. Today, we're going to talk about peripheral nerve blocks. It's something that I find very exciting, and I know that over the last year of doing this, a lot of you guys have helped with assisted with the nerve blocks. Thank you for assisting. And some of you have had some questions. Hopefully we can answer some of these questions and get you a little bit more familiar with these nerve blocks. Let's just first start off by looking at our objectives for the day. What we'd like to talk about is what are peripheral nerve blocks and how do they work? We'll talk about some advantages for doing a nerve block, some contraindications of when you should not do a nerve block. We'll look at some complications that can happen after a nerve block and things that you should look out for and be aware of. And we'll take a look at a few of the different nerve blocks that we do here at Downey. We'll look at some of the techniques involved when we are doing the nerve blocks that you may see us do. And then we'll talk a little about what to expect when you are helping to assist in a nerve block. This was a funny little cartoon I found online, and contrary to what a lot of people believe, this is not how peripheral nerve blocks work. So when we're doing a nerve block, what we're really doing is we're injecting local anesthetic very close to a nerve or a group of nerves in order to prevent the patient from having the sensation of pain during surgery. A couple of examples of very common local anesthetics that we use include lidocaine, ropivacaine, bupivacaine. Let's look at how these nerve blocks, these local anesthetics work. On the top picture you see a neuron, a nerve cell, and on the side you will see this is the membrane of the cell right here. And local anesthetics block the sodium channel here and prevent negatively charged sodium channels from entering the cell. By doing that, it prevents depolarization of the cell. And when you don't have depolarization, then you can't have an action potential. So that's how local anesthetics work. They prevent the action potential. They prevent the signal that the nerve that is sending to the brain that there is pain involved. Let's move on to talk about some advantages of doing peripheral nerve blocks. One of the advantages is that peripheral nerve blocks can provide better pain control in certain cases than using standard narcotics alone. And with better pain, patients have a better experience and they have more satisfaction with their care at the hospital. A second advantage of peripheral nerve blocks is that you can, it allows you to use a whole lot less narcotics and in turn have less side effects that you would get with narcotics, such as post-op nausea, vomiting, respiratory depression, oversedation, addiction. Nerve blocks aren't really new. They've been going on across the nation for over 20 years, but I think that they're becoming a little bit more popular nowadays because with the rising cost of healthcare, a lot of hospitals and surgery centers are focusing more on decreasing the length of stay of patients and decreasing complications such as respiratory depression, nausea. So that's why they become a little bit more popular. Just a word on addiction. You know, everybody who's been paying attention to the news has heard that we are in an opioid crisis, and some of that is coming from overseas. But as a hospital, as doctors and nurses, we have a part to play in that. According to the website drugabuse.com.gov, they followed a large group of patients who had simple, uncomplicated outpatient surgeries, and a year after their surgery, they were still, 6% of them were still using narcotics. According to the same website, they polled people who were abusing heroin, and 80% of them said that the first drug they started abusing was prescription narcotics, either that they got from outpatient surgery or friends or family. So it's a big picture, but we also can play a part in that and prevent that from happening as well. Other advantages, which we talked a little bit more earlier about, is early ambulation, faster recovery from the PAC view, earlier discharge home, and sometimes it's nice to have avoidance of general anesthesia or airway manipulation. Sometimes a patient's too sick to undergo general anesthesia, and you can do a nerve block for them. So let's move on to contraindications for time when you would not want to use a nerve block. I think on here, the only two that are real hard contraindications are a patient refusal and allergy to local anesthetics. Other things are soft contraindications, such as localized infections at the site where you want to do the injection, or if the patient is anticoagulated or has a coagulopathy. You kind of have to weigh the benefits of doing a nerve block versus their condition. Let's talk about complications that can happen after or during a nerve block. These are some things that you should look out for. The first one is probably the most important. It's local anesthetic systemic toxicity. It's rare, but it is life-threatening. This occurs when local anesthetics enter the circulatory system, and then from the circulatory system go to the heart, in which it can cause cardiac arrest, or when it goes to the brain, it can cause, when it goes to the brain, it can cause seizures. We'll talk a little bit more about local anesthetic toxicity, systemic toxicity on the next slide. But other complications that can occur is intraneural injection or nerve damage, bleeding, infection, and sometimes you can have a failed nerve block. So with LAST, or local anesthetic systemic toxicity, the treatment for that is intralipids. You would give a bolus, and then you would give a continuous infusion. The bolus of 1 to 1.5 milliliters per kilo, and then an infusion of 0.25 to 0.5 milliliters per minute. You would also have to treat them if they go into cardiac arrest by calling a code, performing CPR, chest compressions, ventilatory support, intubation. You would treat seizures with benzodiazepines. Does anybody here know where they keep the intralipids? Yes. They keep it in the anesthesia drug room. You have to go through 2 security doors, and this is where the anesthesiologists keep their locked narcotics. If you look, let me see, I'll point out. Right here, right in between the yellow and red bin is a tiny little green bin that has where they keep the intralipids. In case someone codes or has a seizure during a nerve block, this is where you would get the intralipid. And this is what it looks like. It's a white fluid. It looks like a bag of football. Except you'll read on top, it says neutral lipid, 20% IV fat emulsion. The way that it works is that the lipids bind the local anesthetic and take it out of circulation. So we're going to move on to talk about a couple of the different types of peripheral nerve blocks that can be done. This is just a few examples, but there are upper extremity nerve blocks like the interscaling, the supraclavicular, the axillary. There are lower extremity nerve blocks like the femoral, the adductor canal, the sciatic, and the popliteal. And then there are truncal blocks like tap blocks. Let's first talk about the upper extremity nerve blocks. These nerve blocks all involve the brachial plexus, and if you remember, the brachial plexus starts off high as the roots, and then they combine to the trunks, and then they divide into divisions and chords, and then they finally end in the terminal branches with the radial nerve, the median nerve, and the ulnar nerve. And depending on where you block the nerve will determine which dermatome is blocked and will determine which one you would use for different types of surgery. For example, this is an interscalene nerve block. It's blocked at the highest level of the roots, blocked at C5, C6, and this is used for shoulder surgeries. A special consideration for the interscalene block, in addition to the other complications that we talked about earlier, other complications can include a tension pneumothorax. If the needle punctures the lung,
Okay, thank you.
and because the neck is such a tight space and there are other structures involved, other nerves and other blood vessels, sometimes the local anesthetics seep out of the brachial plexus and they affect other tissues. For example, sometimes the local anesthetic diffuses out and affects the phrenic nerve. The phrenic nerve is supplied by C3, C4, and C5. And sometimes when it blocks the phrenic nerve, which controls your diaphragm, patients may have a partial diaphragm paralysis and may experience shortness of breath. Sometimes the local anesthetics can diffuse out and you might get a sympathetic block in which patients may have a Horner syndrome. They might have meiosis, anhidrosis, ptosis, and vasodilation. So you might see a patient with a constricted pupil and a droopy eyelid, and sometimes that can mimic the signs of a stroke, but you should know that it could be a minor side effect of the block and not particularly a severe stroke. You could also have a laryngeal nerve block, and the patients may complain of some hoarseness. Let's move on to the supraclavicular block. It's a little bit lower than the interscalene block, and it works on whereas the interscalene was blocking the roots, the supraclavicular blocks the trunks and division, and this nerve block is good for surgeries distal to the shoulder. So while the interscalene was great for shoulder surgeries, the supraclavicular is great for surgeries after the shoulder. Because it is so close to where you place the interscalene nerve block, it has very similar complications such as phrenic nerve block, Horner syndrome, and tension pneumothorax. Next is an example of an axillary nerve block. These block the terminal branches of the brachial plexus, and they're great for surgeries distal to the elbow. The advantage of this nerve block is that you don't get the other side effects that you did with the first two nerve blocks, such as tension pneumothorax, phrenic nerve block, because the block is so far away from the lung. Now let's move on to lower extremity nerve blocks. These nerve blocks involve the lumbar and sacral plexus, and one example of a lower block is the femoral nerve block. It's comprised of nerves from L2 to L4, and these are great for hip and knee surgeries, total knee arthroplasties, hip fractures, above knee amputations, below knee amputations. But you should be aware that this block only is a partial block, and a lot of times you may have to do a second block to cover the entire leg. Here is an adductor canal block, and if you don't remember any of the other nerve blocks, you should probably remember the adductor canal block. It's a very simple block, and it's the one we use most commonly here at Downey. All the orthopedic surgeons are asking for this block for their total knees now. It blocks just the sensory branch of the femoral nerve, and so you have the motor branch still intact. And the advantage of that is that now the patients don't feel pain, but they're still able to stand up and ambulate and participate in physical therapy after surgery. Here is an example of popliteal nerve block. This blocks the sciatic nerve behind the knee, and it's great for surgeries below, on the lower leg, the foot, and the ankle. One thing to note about this block is that a side effect is patients will have a foot drop which can prevent them from walking safely on their own for the first day and a half. And then we have here a tap block, or what they call a transversus abdominalis plane block. It's used for abdominal, lower abdominal surgeries below the umbilicus. It blocks T6 to L1 nerve roots, and it's good for open inguinal hernia repairs, appendectomies, C-sections. So those were a couple of examples of the different types of nerve blocks. There are a whole lot more nerve blocks that we won't talk about, and it's a never-changing field, and new nerve blocks are coming out all the time. Let's move on to talk about the injection techniques, what you'll see us do during a nerve block. You may notice that before we inject, we'll always aspirate, and we're doing that to make sure that we don't get any blood back, because if you get blood back from the needle, that indicates that the needle is intravascular, and you don't want to inject any local anesthetic into the circulatory system. You might get LAS syndrome. We may also ask you if you feel any resistance when you're injecting injecting the syringe, and this is because if the needle is within a nerve, intraneural, then you'll get a lot of resistance, and if that's the case, then the block has to be stopped and the needle has to be repositioned. And let's talk about nursing assistants, things that could really help us out during a block, things that you could do to really facilitate the block. First, there's a lot to do, but if the nurses are able to put on monitors to the patient, that would be very helpful. And these monitors are very helpful because they can tell us if the patient goes into cardiac arrest, or if they're having a seizure, if they're desaturating from the sedation. Then nurses can also help us out with the timeout to make sure that there's no errors in blocking the wrong limb. Then it's also important to monitor the patient afterwards. Most of the complications of a nerve block or a LAS syndrome will probably happen within the first couple of minutes of the injection, but sometimes it can be delayed, and it can happen 20 minutes afterwards. So they recommend monitoring the patient for about 30 minutes. And while you're monitoring the patient, it's important to realize that if they've had a lower limb block, to be careful not to allow them to ambulate on their own to the restroom, because they are at risk for falling. So that concludes my talk on peripheral nerve blocks. Thanks for coming. Thanks for assisting over the last year with these nerve blocks. Things have gone very well, and we hope to continue all of this.
So, questions?
Any questions?
Questions?
Yes.
So with any one of these nerve blocks, are you giving the same concentration for each one of them?
No. Different nerve blocks require different concentrations. Sometimes the different concentrations and different types of local anesthetics are used depending on how long you want the nerve block to last. Some local anesthetics last long, like bupivacaine, and they're used for surgeries that are painful afterwards. Some are used short-term, like lidocaine, and therefore short surgeries that don't have a lot of pain. Some are highly concentrated because it's a small area that you're trying to block one nerve. And then there are other nerve blocks, like the tap block, where you use diluted concentrations because it's a field block and you're trying to cover several different nerves.
Okay, so like when you're trying to tell these patients how long this block's going to last, so like with the interscaling versus the adductor, about how long are these going to be doing an exercise?
On average, about 12 to 24 hours. Any other questions? Yes.
Just with the setup, I guess we're a little bit more anxious with the nerve blocks because the nerve blocks are fairly new with us.
Sure.
So I guess we're a little more hesitant to participate because we really haven't had much training as far as the setup. The setups that we're used to, primarily sterile setups, towel off, gloves, mask. We still have some parts to learn. it's not, kind of our norm, just to kind of see
Yeah.
the procedure happen.
Sure.
So, you know, we try to feed tidbits, you know, changing needles, watching the technician, the ultrasound tech, if, you know, the cable might come into contact with the skin, but, I guess those are things that we're learning on how to
Yeah,
help.
this is all new, and, you know, that's a great question, because, you know, because this is all new and you're kind of, this is evolving, and as we're getting new equipment, new material, the setup's gonna be a little different, and because different people are doing nerve blocks, they are used to different setups. It's kind of an evolving process. And eventually, down the line, you know, we'll get to a more standardized process. As, you know, we're working on a nerve block cart or kit. Right now, it's kind of crazy. We're running several different places to get equipment from different parts of the hospital. But eventually, you know, we'll get all the equipment all in one place, and then we'll have a standard setup. So right now, there is a little chaos, but, you know, we'll help direct. And, you know, I know you had some questions about how sterile should the block be. Most people say that it should be a clean block, but it doesn't have to be necessarily a sterile block. You know, should you put on the ortho hats and fans to do this block? Probably not. Because right now it's just an injection, we're not leaving in any catheters that could leave infections. It doesn't have to be super sterile. It does have to be clean, and you don't want infections. But again, infection, if you are careful with your technique, and you're clean, and you make sure not to contaminate things, infection is pretty rare. I don't know if that answers your question.
A little bit, just because sometimes you'll see, you know, the sterile gloves will be placed, but then you're handling the probe
Yeah.
and manipulating the needle, switching hands.
When I do it, I make absolutely sure not to touch the needle. Like I said, it's a clean procedure, not necessarily a sterile one, and almost it's very hard to avoid